on the use of alpha blockers in hypertension. Before we get into these details, it is important to know that the adrenergic receptors are of two types, alpha receptors and beta receptors. The alpha receptors are in turn divided into two subtypes, that is alpha 1 subtype and alpha 2 receptor subtype. Alpha blockers produce pharmacological actions by antagonizing alpha receptor mediated actions. We classify the alpha blockers into two types based on selectivity. That is non-selective alpha blockers that includes drugs such as Phenoxybenzamine Phentolamine Tolazoline. The selective alpha 1 blockers are Prazosin Terazosin Tamsulosin and Tamsulosin. Coming to the use of alpha blockers in hypertension. Remember, we have learned that hypertension is of two types, primary or essential hypertension and secondary hypertension. In primary hypertension, the cause is unidentified and majority of the hypertensive patients fall under this category. In secondary hypertension, there is an underlying cause of hypertension such as chronic kidney disease, Cushing syndrome, thyroid disorders. Some of the drugs are also known to cause hypertension. So in this category, the underlying cause needs to be treated in the management of hypertension. It is important to note that in the management of essential hypertension or primary hypertension where the cause is unidentified, selective alpha 1 blockers are the drugs of choice. They are preferred over non-selective alpha blockers. So let us understand with the help of a diagram why selective alpha 1 blockers are preferred over non-selective blockers in the management of essential hypertension. As we can see here, alpha 1 receptors are expressed in the vascular smooth muscles and stimulation of alpha 1 receptors causes vasoconstriction, increase in peripheral vascular resistance and the blood pressure rises. So antagonizing alpha 1 receptor with the help of an alpha blocker decreases the peripheral vascular resistance causing a fall in blood pressure. With the fall in blood pressure, the signals are sent to the baroreceptors which in turn sends impulses to the vasomotor center which causes activation of sympathetic nervous system releasing epinephrine and norepinephrine into the circulation, and this causes rise in heart rate. So a fall in blood pressure is accompanied by a slight increase in heart rate with selective alpha 1 blockers such as Prazosin Terazosin Tamsulosin. So let us see what is the situation with non-selective alpha blockers that block both alpha 1 and alpha 2 receptors, and the drugs are Phenoxybenzamine and Phentolamine. As we can see in this figure, the non-selective alpha blockers, in addition to blocking the alpha 1 receptors that are expressed in the vascular smooth muscle, also antagonize the alpha 2 receptor that is expressed in the presynaptic nerve ending. Now the function of alpha 2 receptor is to inhibit the release of epinephrine and norepinephrine into the synaptic cleft. So alpha 2 receptor has an inhibitory control on the release of epinephrine and norepinephrine. So it inhibits the release of epinephrine and norepinephrine. So alpha 2 blockade action caused by the non-selective alpha blockers which block also alpha 2 receptors. So by blocking the alpha 2 receptors, the inhibitory control is lost and there is excessive release of epinephrine and norepinephrine into the circulation, and this epinephrine and norepinephrine stimulates the beta 1 receptors of the heart causing tachycardia as a side effect. So non-selective alpha blockers produce significant increase in heart rate, and this is particularly a matter of concern in elderly patients or in cardiac patients. There is increased risk of tachyarrhythmias, and therefore non-selective alpha blockers are not preferred for the treatment of essential hypertension. Therefore, selective alpha 1 blockers such as Prazosin Terazosin are commonly used for the treatment of hypertension. So let us now learn more about the selective alpha 1 blockers that are known to antagonize alpha 1 receptors expressed in the vascular smooth muscle, decreasing the peripheral vascular resistance and lowering the blood pressure, and this is accompanied by a slight increase in heart rate. Now, the drugs that are commonly included in this category are Prazosin, Terazosin, Tamsulosin and Tamsulosin. Prazosin has an oral bioavailability of 60% and the plasma T half is 6 to 8 hours. Therefore, it is administered twice to thrice daily. Caution is necessary while prescribing prazosin because it is known to cause first dose hypotension. 1 hour after an initial dose of prazosin, there is marked postural hypertension and this can lead to fainting. Therefore, prazosin is started with a small dose of 0.5 mg and is taken at bedtime. The other side effects of prazosin are headache and dizziness. The next alpha-1 selective blocker is terazosin. Terazosin has a bioavailability of 90%. It has a long plasma half-life compared to that of prazosin and therefore it is suitable for once daily administration. One of the characteristic features of terazosin is that it can induce apoptosis of the smooth muscle cells of the prostate and therefore it is useful for the treatment of benign hyperplasia of prostate, a condition in which there is enlargement of the prostate gland and this presses the urethra causing obstructions in the urinary flow and causing symptoms of lower urinary tract. Therefore, the patient complains of urgency in urination, difficulty in passing urination. Thus, terazosin is preferred in a hypertensive patient with benign hyperplasia of prostate because it lowers the blood pressure and also relieves the symptoms of lower urinary tract due to obstruction of the urethra because of enlargement of the prostate gland. So, hypertension with benign hyperplasia of prostate, terazosin is the drug of choice. So the next drug is tamsulosin. Now tamsulosin is a uroselective agent. It selectively blocks alpha-1A and alpha-1D receptors that are present in the smooth muscles of the bladder and urethra. It has minimal action on alpha-1B receptors that are present in the blood vessels. So therefore the effects of tamsulosin are targeted for the smooth muscle receptors of the urinary bladder and the urethra, and this causes relaxation of the urinary bladder, dilatation of the urethra, relieves the urinary flow and helps to relieve the symptoms of lower urinary tract obstruction due to enlargement of prostate. So tamsulosin is a selective alpha-1 blocker that has no antihypertensive efficacy. It has no blood pressure lowering potential, but it is very useful for the symptomatic relief in benign hyperplasia of prostate, where the symptoms of urinary obstruction are relieved and therefore it is the preferred drug in the management of benign hyperplasia of prostate. So, some of the additional benefits of these drugs are they have favorable lipid profile, they do not influence the blood glucose level or plasma uric acid level. Therefore, they are preferred for the treatment of a patient with diabetes, hyperlipidemia and a patient with gout because there is no influence on the uric acid level. So in conclusion, prazosin is widely used in the management of hypertension. Terazosin is the preferred drug for the treatment of hypertension and benign hyperplasia of prostate, and tamsulosin is the preferred drug for the treatment of benign hyperplasia of prostate. It has no blood pressure lowering potential, no antihypertensive efficacy. So coming to the role of non-selective alpha blockers in the management of hypertension. Phenoxybenzamine, a non-selective alpha blocker that blocks both alpha-1 and alpha-2 receptors, is useful in the treatment of pheochromocytoma. Pheochromocytoma is a tumor of the adrenal medulla that produces excessive secretion of epinephrine and norepinephrine into the circulation, which causes symptoms of palpitation, raised blood pressure, sweating and tremor. So let's see what is the pharmacological basis for the use of phenoxybenzamine in pheochromocytoma. So what is the pharmacological basis for the use of phenoxybenzamine in the management of pheochromocytoma? As we can see in this figure, phenoxybenzamine has high affinity for alpha-1 receptor. It binds strongly with the alpha-1 receptor, forming covalent interactions, and since the binding is very strong, it is not easily displaced by even large quantities of epinephrine and norepinephrine. So even if large quantities of norepinephrine and epinephrine are present in the circulation, the displacement of phenoxybenzamine from the alpha receptor is less likely because the binding is very strong, the binding is irreversible, and the action is long lasting. Therefore, it is a preferred drug for the management of pheochromocytoma when large quantities of catecholamines are present in the circulation. One of the drawbacks of phenoxybenzamine is that it can cause significant tachycardia, and this is due to the action on alpha-2 receptors, which causes further release of epinephrine and norepinephrine into the circulation, which acts on the beta-1 receptors of the heart, causing tachyarrhythmias. And therefore, phenoxybenzamine, which is a non-selective alpha blocker, is administered along with a beta blocker to control the increased heart rate, to control tachycardia. Thus, phenoxybenzamine, a non-selective alpha blocker, is administered along with a beta blocker, and this helps to bring about hemodynamic stability. Now the question arises about the timing of administration of beta blocker. Should the beta blocker be administered together with an alpha blocker, or should it be administered before or after the administration of an alpha blocker? So let us see why a beta blocker should be administered only after the administration of an alpha blocker, only after adequate alpha blockade has been achieved. So let's understand this with the help of a diagram. Now, if beta blocker is administered alone, that is, in the absence of an alpha blocker, a beta blocker will inhibit the beta receptors of the heart, inhibiting tachycardia, and also it will inhibit the beta-2 receptors of the blood vessel, which is responsible for relaxation and causing a fall in blood pressure. So, when the beta-2 receptor is inhibited by a beta blocker, what remains is the alpha-1 receptors in the vascular smooth muscle. And when the beta-2 receptor is inhibited, there is unopposed or excessive stimulation of the alpha-1 receptors, causing vasoconstriction, rise in peripheral vascular resistance, and rise in blood pressure. So, excessive stimulation of alpha-1 receptors in the absence of an alpha blocker will cause severe rise in blood pressure. This can aggravate the hypertensive crisis. So, an alpha blocker should be administered prior to the administration of a beta blocker so that the alpha receptors are blocked first, and then when the beta blockers are administered, they can block the beta-2 receptors of the blood vessels, and the beta-1 receptors of the heart is also blocked, and this helps in controlling tachycardia and brings about hemodynamic stability and controls the hypertensive crisis. So in conclusion, beta blockers are always added to alpha blockers for the management of hypertensive crisis in pheochromocytoma, but they should be administered only after adequate alpha blockade has been achieved, only after the administration of an alpha blocker, and this is how it controls tachycardia and brings about hemodynamic stability. So because of these pharmacological actions, phenoxybenzamine is used in the surgical removal of the tumor. It is given 21 days prior to the removal of the tumor, and this prevents excessive release of catecholamines into the circulation and helps in maintaining hemodynamic stability, controls tachycardia in the management of pheochromocytoma. The next drug is phentolamine. Phentolamine is also a non-selective alpha blocker and is used in the diagnosis of pheochromocytoma. It has a rapid onset of action and a short duration of action, and so is useful for the diagnosis of pheochromocytoma. 5 milligrams of phentolamine given intravenously if the fall in blood pressure is greater than 25 to 35 mm of mercury, then it is suggestive of pheochromocytoma. But if the blood pressure reduction is less following phentolamine administration, then it is indicative of essential hypertension. Thus, phentolamine is used for the diagnosis of pheochromocytoma, and phenoxybenzamine is used for the treatment of pheochromocytoma. Lastly, some of the side effects associated with non-selective alpha blockers are nasal stuffiness, ejaculatory dysfunction because of blockade of alpha-1 receptors in the ejaculatory duct that obstructs ejaculation, and tachycardia and postural hypertension are also some of the side effects as we have already discussed. So in this lecture, we have covered the uses of selective alpha-1 blockers in the management of essential hypertension and also the uses of non-selective alpha blockers such as phenoxybenzamine in the management of pheochromocytoma, a tumor of the adrenal medulla and a secondary cause of hypertension. Thank you so much for watching.